Cancer, a significant public health concern and a leading cause of cancer-related deaths among women in Kenya. Welcome to Focus on Health, a show on all matters health, wellness, and lifestyle. I am your host, Rebel Fender, and on today's episode, we will be discussing cervical cancer alongside Dr. Benjamin Eli Odongo, a gynecological oncologist. But before we dive in, take a look at the health updates. So, Doctor, kindly tell us, what is cervical cancer?
We first have to understand what the cervix is. Cervix means neck. So, in fact, one day I was surprised, cervical cancer, people start touching their necks, whether there is any cervix. But in this, for purposes of this discussion, the cervix is the lowermost portion of the uterus. So, in layman's terms, it's just to say it's the entrance to the uterus. Other people say the mouth of the uterus, the lowermost portion. And it's that area that when one is in labor, it what dilates to allow the baby's head to pass. And you hear terms like 1 is 4 centimeters dilated, 5 centimeters dilated. They are referring to that part of the body. So, cervical cancer is a malignancy or a cancer that affects that particular part of the uterus. The body, the entrance or the lowermost portion of the uterus. Just to give the statistics, the new cases so far that we see in a year are close to 6,000, and the ones that suffer really the bad outcomes in terms of mortality, at least half of them, around 3,000 deaths arising from cervical cancer. So it's good. It's an important public health concern, mainly because it's preventable. It's preventable because it has got a very long latent phase from infection by HPV, which we talked about a few moments ago, to the final development of cancer. So there is a long latent phase, which gives us a window of prevention of cervical cancer.
Okay. So maybe you can correct me if I'm wrong. Is there a reason why it is so much prevalent right now as compared to a long time ago? We never used to hear cervical cancer as much.
It is prevalent because I think there's more increased awareness. Personally, I still believe that we still had cervical cancer. Because when we were training in the 90s, we still used to see cervical cancer. But currently, because now we have a lot of awareness and a lot of centers now that have come up to take care of our women with cervical cancer, increased awareness that you need to be screened. If you see abnormal bleeding, you need to go to hospital. Then the numbers are bound to come up. And also our population has expanded. 10% of the population 10 years ago is not the same 10% of the population now. So which means that the numbers we are seeing could still be proportionately comparable to what we were seeing in the past.
Okay. So also, what are the risk factors associated with getting cervical cancer?
Yeah, we talked about human papillomavirus, and any condition or situation that puts you at the pathway to acquiring human papillomavirus puts one at the risk of cervical cancer. And in this case, acquisition of HPV, which is mainly sexually transmitted. And therefore it goes without saying that if one has multiple sexual partners, then one puts self at a higher risk of acquiring HPV and subsequent cervical cancer. Notably, if one acquires HPV when they are young, when the cervix is still developing and there's a place we call transformation zone on the cervix that undergoes a lot of cellular changes. If one acquires infection during that time, during adolescence, then you are also at higher risk of developing cervical cancer because of the transformation zone is quite active. Therefore, this brings me to one point of early sexual debut, which also is a risk factor. and multiple sexual partners. Then there are also other cofactors. One of them I talked about immunosuppression, and one key immunosuppressant is, for example, smoking. So smoking has an effect on clearance of the HPV. Remember, we said that the issue is not the infection per se. The issue is about clearing the disease once one is infected. Then other cofactors include co-infection with other sexually transmitted diseases. For example, chlamydia, herpes simplex that we talked about. And so I think those are the main ones that put our population and our men on the path to acquiring the cervical cancer.
Okay, so does genetics also play a role in the transformation from pre-malignancy to malignancy?
No, not for cervical cancer. There are some cancers that have, of course, predisposition by genetics. For example, uterine cancer, some uterine cancers, which you can see in the hereditary non-polyposis colon cancer syndrome, or breast and ovarian cancer in the breast ovarian cancer syndrome. But in cervical cancer, the association is mainly with the human papillomavirus.
Okay, so also using contraception, is there a risk for getting cervical cancer? Does it also promote?
Yeah, that has been debated, and I wouldn't want to answer that conclusively now, because there are still studies going on regarding the use of Depo-Provera and combined oral contraceptives as a promoter for cervical cancer. Not conclusive though, because some is due to association or postulates that those who are on contraception could be more sexually active. Not necessarily true. Yeah, but we know that barrier methods tend to kind of reduce the HPV acquisition, and we talked about it. Not 100%, because even just contact itself can predispose to HPV acquisition.
So what are the symptoms associated with cervical cancer?
Yeah, so like I said, it progresses from pre-malignant to malignant. In the pre-malignant phase, there is really nothing. The woman feels nothing. But once they start having invasion and being cancerous, then you start having abnormal bleeding. The bleeding could be mainly due to contact bleeding. By contact, I mean bleeding after sexual contact, postcoital bleeding being a major presentation, or intermenstrual bleeding in between periods, or bleeding when one is going for a long call or a short call. We call that Valsalva maneuver, when there is increased intra-abdominal pressures. In addition to bleeding, you can have persistent vaginal discharge, which is usually watery. Most of the time it is watery, and after some time it becomes foul smelling because of, we call it necrosis and sloughing off of the dead cells from the cervix, foul smelling vaginal discharge. And as the disease spreads, you start having pain. Chronic pain could be lower back pains or lower abdominal pains, mainly because of the spread of the disease. And sometimes because it spreads and blocks the passage of urine, blocking the ureters. The ureter is the pipe that joins the bladder, the urinary bladder, to the kidney. As the disease is spreading, sometimes it can block it and leads to what we call hydronephrosis. Hydronephrosis meaning that the ureters are dilated, causing blockage due to the blockage by the cancer, and so presents with flank pains or signs and symptoms of kidney failure because of the blockage of the ureter. And of course, general ill health, by the time the cancer is spread, because there are some immune modulators that are produced by malignant cells that really gives one general ill health, including anemia, dusk skin, amongst other presentations. Let me also mention that occasionally you have got what we call the terrible triad of cervical cancer, whereby you have only unilateral leg swelling, whereby the unilateral means one leg is really swollen, and that one is usually due to formation of blood clots. And the other one is, of course, I already alluded to flank pains, and sometimes if the nerves are involved, a lot of pain behind the leg. We call it sciatica. That's really is the common presentations that we see amongst our women. One more thing is that the women with immunosuppression, especially HIV, are 4 to 5 times more at risk of developing cervical cancer, mainly because of they're not able to clear the HPV. And so quite a number of our HIV units, if women come with this bleeding and all the symptoms I've described, it's good to examine them and confirm that they don't have cervical cancer.
So could you elaborate what the staging for cervical cancer is? We hear a lot of stage 1, stage 2, but we don't understand.
Yes, staging of cervical cancer is both clinical. By clinical, I mean from a clinical examination of the patient, and radiological, meaning after you do imaging. Mainly MRI or CT scan can also help you with the staging. So because I don't want to go so deep for our audience, but it's mainly stage 1 to 4, whereby stage 1, you can have a disease that is localized to the cervix. Stage 1A is microscopic disease. You can't see it with the naked eye. 1A. But 1B, if you do a speculum, you examine the cervix, you will see a lesion. Then 1B, you classify it further depending on the size of the lesion. 1B1 with less than 2 centimeters, 1B2, 2 to 4 centimeters, and 1B3 more than 4 centimeters. I already mentioned that the disease spreads, so once it has started spreading either to the vagina or to the lining, the sides of the uterus, it goes to stage 2, where we've got 2A, 2B, and then stage 3, it already spread to the lower vagina. When it blocks the ureter, it's already 3B. And then 3C is now what you see on the imaging, whether CT scan or MRI. If the lymph nodes are enlarged, then you know you have a stage 3C. And 3C can also be divided into 2, 3C1, 3C2, and have a superscript, whether it's R or P, where R is radiological, where the pelvic nodes is 1, and nodes around the para-aortic, that means in the abdomen already is a 3C2. And then stage 4, of course, 4 is spread to local structures in the pelvis, would be spread to the rectum behind or the bladder at the front, or that's stage 4A, or when there is now a communication between the bladder and the vagina whereby there's continuous leakage of urine, that's stage 4A. But stage 4B now is when there is a distant spread.
Okay, so at what point do we now say it has been detected early and detected late?
Yeah, so we have two main early detections. One is microinvasive disease. Microinvasive disease, like I said, is stage 1A. 1A, and I said 1A also has some sub-classifications. I've got 1A1 when there is less than 3 millimeter invasion, and 1A2 less than 7 millimeter invasion. Let me take it again. Up to 3 millimeters is stage 1A1, and 1A2, 3 to 7 millimeters invasion. That's what we call microinvasive disease. That's a very early disease which can easily be managed by simple surgery, or even 1B1 when the tumor is less than 2 centimeters. But from experience now, once you start getting to 1B2, 1B3, then it's not really early, because even the treatment will be a little bit more aggressive as opposed to the very early microinvasive disease.
We're taking a short commercial break. Do not touch that dial. We'll be right back. But before then, take a look at the Did You Know segment. Welcome back to Focus on Health. We are continuing the conversation on cervical cancer alongside Dr. Benjamin Eli Odongo. Take a look. So maybe you can take us through the management of the different stages of cervical cancer.
Yeah, the management of cervical cancer really is about also the desire of the woman. Because we now have women, career women, who want to start their families late, and they come with maybe a microinvasive disease or early cervical cancer. So in such cases, you do fertility sparing procedures, which can either be resection of that part of the cervix, we call it cone, for microinvasive disease, or you can do what we call trachelectomy, remove the cervix but leave the uterus in place, where in that case then you have to put a stitch on the neck of the uterus because you have now compromised the ability of the uterus to carry a pregnancy. So this is for early disease. Like I say, you are tailoring it to the woman's need. But if it is, let's say, a woman does not really desire fertility, then you can offer, for early stage, you can offer surgical option, which can be a simple hysterectomy if it's a microinvasive disease. Or if it's stage 1B1 or 1B2, you can offer radical hysterectomy, whereby you remove the uterus with its support structures and a big chunk of a good cuff of the vagina, and then you also remove lymph nodes, the pelvic nodes. And then subject them for histology because they can give you the final stage. Okay. However, when the disease is advanced, it's good not to give women two modalities of treatment. You choose one. In this case, we go for concurrent chemoradiation for those who can fit in that group. Occasionally, we find the disease has spread to other parts of the body, and you cannot radiate the whole body. So those women are now, you discuss the goal of care, which most of the time is palliative because you may not cure them of the disease. So you have to give a systemic chemotherapy. Okay. Yeah.
Okay. What about the precancerous lesions? Is there any management for that?
Yeah, precancerous lesions, it also depends on the fertility desires. For precancerous lesions, we have got CIN1, which means cervical intraepithelial neoplasia 1. The abnormal cells are in less than a third, lower third of the lining of the cervix. You can actually follow them up because they tend to regress. CIN1 regresses up to 57 to 60% of the time, and then you review after a year.
So how do we manage precancerous lesions?
Yeah, precancerous lesions means the lesions that are on the cervix, but they are on their way to becoming cancer. They're actually classified into 3, what we know as cervical intraepithelial neoplasia, CIN. So CIN1 means that the abnormal cells are in the lower third of the thickness of the cervix. And in this case, these women can actually be followed up, mainly because CIN1 tends to regress most of the time, 57 to 60% of the time. But when you have CIN2 or 3, whereby there is either more than a third of the thickness of the cervix being involved, that's CIN2 or CIN3, the entire thickness, then something has to be done. Either an excision procedure or an ablation procedure. By an ablation means you either use cryotherapy using freezing mechanisms or laser or thermocoagulation, which the disadvantage is that you don't get any tissue from it to submit to the pathologist to examine. Or you can do an excision procedure. The excision can either be done using a knife or a blade, we call it cold knife conization, or you use a loop of electricity, a loop with electrical current, also known as loop excision, loop electrosurgical excision procedure. So that's the summary. When you have a premalignant condition of the cervix, you can either follow up, but if you are a little bit severe, then you can either do an ablation procedure or you do an excision procedure for it.
Okay, so you also mentioned about the screening. So at what age should someone start getting their screenings?
Yeah, remember we are now going towards HPV DNA screening. Initially, as in our government programs, we had thought that we should start HPV DNA screening at 25 years. But these are still very immunocompetent people, sexually active. So you may overwhelm the system if you want to screen everybody at 25. So that's why we have pushed it to 30 to start HPV DNA screening at 30. So we hope that these guidelines will be approved when the recommendation of screening at 30 HPV DNA.
Okay, so there's also a lot of mention of palliative care. So what is this, and at what stage is one liable for palliative care?
Yeah, palliative care usually is care you give to patients with malignant disease. Ideally, palliative care should be begun much earlier. It's part of the care as you are treating the disease, but it's now evolved towards care of the terminally ill, whereby the aim is to ensure that there is dignity even in sickness and disease. So it has many components, including spiritual component, spirituality, faith, alleviation of pain and suffering, correction of derangements in the body, maybe as a result of the disease process. So this is what it really entails. I may not answer so much about palliative care because there are really other palliative care specialists who have more detailed information on how this can be conducted.
Okay, and when it comes to management of cervical cancer, how long does this take?
Well, it depends on the stage. For example, if it is surgically amenable disease, just do the surgery and then you follow up the patient for up to 5 years. Same with the radiation. If you radiate, ideally when you start radiation, you should be able to finish it within at least 56 days from start to completion of radiation. Then you still follow them up to 5 years. Then after that, let me correct that. You follow up every 3 months for 2 years, then every 6 months for up to year 5, and then after that annually. We do this because most recurrences occur within 2 years. So when they recur, then you also have specific management options for those who have recurrent disease.
And what are they?
Yeah, so it depends on the recurrence. If, for example, it depends on the site of recurrence and also previous management. If patient was managed surgically and recurs, then they can undergo radiation. If a patient underwent radiation and recurs, then you decide, you re-image and say, is it central recurrence, meaning it's a very small tumor that has recurred in the center of the cervix or the vagina? If it's a very small tumor, less than 2 centimeters, you can offer a surgical option, which can either be a hysterectomy if the uterus is still there, or an exenterative procedure. Exenteration means you either remove the part with the disease and also another organ. You can even end up removing the bladder and the rectum, and in that case you have to fashion a permanent colostomy or an ileal conduit for the urine. But if it's recurrence after radiation also, and patients that are amenable to surgery, then you can use agents that are available now, which include chemotherapy, targeted therapy, like we have drugs that target the vessels, a drug with vascular endothelial growth factor inhibitor like bevacizumab, or immunotherapy using pembrolizumab. So there are agents that can help manage when the disease recurs. But notably is that when you have managing patients in this scenario, you should always discuss with the patient and the family what the goals of care are. Because when you are dealing such a state, then it's not only the cost but also the side effects can be unbearable to some of the patients. I may give examples of side effects including hypertension for bevacizumab, maybe DVT, formation of blood clots, and perforation of the intestine, gut perforation, and the expense notwithstanding of these agents.
Okay. Does this type of cancer regress?
I wouldn't say regress. They can be cured. Let me put it that way, because when you're radiating, when you're doing a surgery with the intent to cure. That's why you have to choose the patient, surgical patients carefully with regard to cervical cancer. You choose, patient selection is key. Well, if you are sure that you're able to go around the disease, you stage properly, then you know surgery will cure them, go for surgery. If not, you're giving radiation with intention to cure. So the rest, when you're doing radiation now, is when you now discuss describe the response to treatment. And there are usually 4 possible outcomes. Could be complete response to treatment, whereby the disease completely goes, or there is partial response, whereby there are also measurements to determine the partial response, or you can have stable disease, whereby there is really no change, or progressive disease. You treat, but the disease keeps progressing. Those are the possible scenarios. Okay. Though for cervical cancer, it's one of the cancers that respond very well to concurrent chemoradiation for the advanced disease. And for the good surgical candidates, surgery is usually enough for them.
Okay, so as we finish, kindly emphasize on the ways you can prevent cervical cancer.
Yeah, prevention of cervical cancer is about screening. The countries and the regions that have eliminated cervical cancer is about screening. But now we are now under the umbrella of the guidance of WHO elimination strategy. 90% of our girls should be vaccinated. Then there is the 70% screening, and then 90% of those who have been diagnosed with either premalignant or malignant condition receive appropriate care, including palliative care. Yeah.
Okay. So, lastly, kindly give us your parting shots in relation to HPV infection and cervical cancer. You can just look at that.
Yeah, so it's now known that more than 80% to 90% of our cervical cancers are due to HPV, to be specific, HPV 16 and 18. And so if we have got means and ways to prevent either acquisition of HPV or to mitigate the progress, including delaying sexual debut, using barrier methods, uptake of vaccination, and HPV DNA screening at the appropriate age, then this can lead to prevention of premalignant and subsequent malignant conditions of the cervix.
Very elaborate conversation we've just had, and just as Dr. Benjamin has emphasized, cervical cancer is both preventable and manageable. I have been your host, Jebo Fenda, and until next time, stay safe, stay healthy, and live with the Healthy You segment.